Hello, my name is Klaus Bastel, and we're doing now a wrist stabilization with shark screws. It's a patient with chronic polyarthritis, and first we have to do out all the synovia of the joint and the tendons. And then we fix the joint with K-wires, and then we put in, instead of the K-wires, the shark screws, each one of another. So let's start with the operation.
Preoperative X-rays show marked malalignment and advanced arthritis due to polyarthritis. The patient has suffered from severe pain and restricted mobility for many years. For the wrist arthrodesis, Dr. Pastel used 4 screws made of allogeneic cortical bone, which are gradually integrated into the patient's own bone after surgery. The approach is made via a direct dorsal midline skin incision to the right wrist. The subcutaneous tissue and skin are dissected radially and ulnarly until the cutaneous branches of the radial and ulnar nerves are exposed. The extensor retinaculum is incised obliquely, as it will later be used to cover the exposed bone on the palmar side of the extensor tendons and wrist joint. In this case, the extensor tendon compartments are also affected by extensive synovitis, so a tenosynovectomy is performed. The interosseous nerve is identified, ligated with a 3.0 suture, and cauterized proximally to the ligature using electrocautery. The underlying joint capsule is incised straight, and the wrist is synovectomized using a Luer. Next, the periosteum and joint capsule over the ulnar head are split. The ulnar head is osteotomized and carefully resected to allow free pronation and supination of the wrist following arthrodesis. The joint capsule is further dissected from bone radially and ulnarly to gain full access to the wrist joint. The thickened pannus from the wrist synovitis is meticulously removed using the Luer. The radius reveals deep cysts caused by inflammation. The cartilage is removed partly with a curette and partly using a high-speed burr. Especially on the radius, deep defects are seen, where inflammation has led to undermining of the subchondral bone. Cartilage is also removed in the intercarpal spaces. The wrist is then gradually stabilized using K-wires. First, the proximal carpal row is fixed with a 1.6 mm K-wire. 3 additional K-wires are inserted from the proximal radius to optimally stabilize the carpal bones. Under fluoroscopic control, the position of the K-wires is checked. Only once all 4 K-wires achieve maximum stability in the wrist are they replaced one by one with a 1.2 mm K-wire, over which drilling and tapping are performed. Followed by the insertion of the shark screw. In these cases, a shark screw diver with a diameter of 5.0 mm is used. The screw length can be read from the laser markings on both the drill and the tap. The shark screw diver is inserted continuously into the bone until it is flush with the bone surface. The same technique is used for placing and transplanting the remaining 3 shark screw diver implants. The strength of the cortical bone bridge from the transplant is increased by inserting the screws close to the cortical bone, where the cancellous bone is denser. At the end, the bone screws are cut off at the bone level. In some of the larger bone defects, a paste consisting of demineralized cortical bone, DBM putty, and corticocancellous chips is applied. This ensures that no voids remain between the bones to be fused, which would otherwise prevent bone cell ingrowth and bridging. Finally, the extensor retinaculum is sutured back in place to protect the extensor tendons from the underlying bone. It also serves to enhance stability and improve perfusion of the wrist. The skin is then sutured. Immediately after surgery, a forearm cast including the thumb is applied, which is left in place for 10 to 12 weeks. On the post-operative X-rays, the position of the 4 implanted shark screws is clearly visible, thanks to the structure of the screws made of pure cortical bone. These screws provide excellent stability of the wrist joint. A follow-up X-ray at 10 weeks showed very good consolidation. Over the coming months, the graft will gradually be remodeled into the patient's own bone.